Thanks to everyone for coming and hello to everyone on Zoom. Um, we are very lucky to have Leuchter from UCLA come to tell us about his work. We'll leave you to Google Rich's CV if you want edification about his many accomplishments. I think what I'll say about Rich is that um, I think there's a pretty standard track if you're a young physician investigator at a top medical center, where you just kind of like start trying to get NIH grants and you work your way up the system and you kind of find an area and you find a niche and you just get the machine going. And Rich has clearly started to, do that thing, but he also has a bunch of other really, really interesting and I think stuff that is much more creative and different and higher risk than the standard NIH supported investigator can support. And I'm really happy that you're here to tell us about it. So thanks for coming up. Sorry about the weather. I know this is not LA, but at least we're inside.
Okay, well, thank you for that introduction and for having me here. Very excited to talk to you all. Do I need to unmute or are you?
Why don't you go ahead since you're probably closer?
Okay, perfect. My sound is down, yeah. Okay, perfect. All right. I'll actually stand here. All right. So yeah, like Ziad mentioned, so I'm Rich Leuchter. I'm an assistant professor at UCLA. Clinically, I'm a hospitalist, so that's 30% of my time. I just take care of hospitalized patients. And then the other 70% of the time, I'm a health services researcher. My research background is on applied mathematics and computational medicine. So because my clinical work deals with the acute care setting, my research ends up focusing on how do you make, very specific predictions on acutely ill patients, trying to get them the precise medicine that they need at the exact right time in their care and the exact right scenario and the right treatment setting. So I want to talk to you about evaluating translational AI models in that context. I have no conflicts of interest. And the singular objective for this talk is just to understand three, what I consider to be very high impact implementation methods for clinical translational AI models. And when we're talking about healthcare AI models, we all know that there are numerous tasks that we're talking about. We can talk about diagnostics and detection, like interpreting radiographic images, precision medicine, there's clinician and patient support, like AI ambient listening scribes, NLP tasks, all of these things. But what we're going to focus on today is just this fourth bucket here. And this is by no means the only way to structure it, by the way. But I want to focus on the fourth bucket, which is just patient outcome prediction monitoring and response to treatment. So this can be prognostication of patients, figuring out who's going to have future utilization, who's going to have bad outcomes, adverse events to a treatment you start, things like that. So knowing that we're talking about this type of task, I have structured this talk as three stories that we're going to go through. Before we get to these stories, there's a very short preface that I have to mention, which comes in two parts. And the first part is the data science side. So I work with a lot of data engineers, a lot of PhD students. And one thing I always hear from people who are developing the AI models is, why should I care about implementation? And that kind of falls to the back burner. And what I argue is that implementation should actually be one of the very first things that you are thinking about, because that tells you, as a data scientist, someone who's developing these models, very important answers to questions. For example, should I be optimizing for precision or recall? What type of data am I going to use? Do I have access when this model rolls out? Is this going to be data that's refreshed once a week, once a day? Do I have access to real-time data? All of these things directly inform the model architecture that you're going to be using. To give you a concrete example of this, something that we've recently had to work through is an AI model for allocating ICU beds in a hospital. So ICU beds are a very scarce resource. And you can imagine if you were going to test an AI model that allocates them in a RCT, a randomized controlled trial, you would have, maybe half the patients in a hospital get exposed to this AI ICU bed tool, and the other half of the patients don't. Well, because ICU beds are a scarce resource, if you optimize this model for recall, you would have a lot of false positives, right? You would catch all the sick people, but you would also have a lot of false positives that you would inappropriately allocate ICU beds to in your treatment group. That would deprive your control group of ICU beds, and you would not give them to people who need them there and potentially end up killing some people that way. So you have to know right off the bat for this model, I don't want to optimize for recall. I want to optimize for precision. I want a very high positive predictive value. So when we make a prediction someone needs an ICU bed, we give it to them, but we're not depriving the control group and causing resource mediated spillover. So that's just a brief example of why you need to be thinking about how you're implementing the model from the get-go. The other side of the preface here is on the healthcare executive or the stakeholder side. So this is kind of the opposite issue, which is that executives and physicians and everyone, always want to implement the model. Like if you design a model and the AUC is 0.91 and you show it to them and they say, this is great, I want to roll this out at the hospital. They just want to do a shotgun approach and roll it out to everybody. And they don't always understand the need for rigorous evaluation. And that's because these concepts like model drift and prediction decay aren't always inherent to them. So you have to find a way to explain it in a way that's, digestible for somebody who doesn't have this background. So I have failed for many years in trying to explain that concept, but finally I feel like made some headways there. So I want to share this model basically of how we pitch this to executives and stakeholders and other physicians who are making the decisions, yes or no, are they going to implement your model? So what I tell them when I sit down, with people in the C-suite or other members in the health system leadership is we say, evaluating AI is a two-way moving target. The first way that the target moves is while the model's being developed. So you can imagine, if you're tackling a problem, we'll say in this case, let's say you're trying to build an AI model that can predict length of stay. While you're building that model, the health system is going to implement a slew of other interventions to also try to shorten length of stay for hospitalizations. They're not just going to put all their eggs in your basket. They're going to approach this in multiple ways. So when you have developed your model on retrospective, EHR, electronic health record data, you may have, on your test data set, very accurate predictions. It's performing incredibly well. But the problem is, while in the months it took you to build that model, the health system, like I mentioned, has maybe improved interdisciplinary rounds in the hospital, implemented a financial incentive for the hospitalist to shorten length of stay. They've completely revamped hospital workflows. And what all of those things do is they morph length of stay into something that's fundamentally different than what you trained your model to predict. So that's effectively concept drift right here. So now when you go to implement your model in a prospective EHR environment, all of a sudden your predictions now look very inaccurate. And this leaves you as the researcher wondering what happened to my AUC. And the health system says, I'm sorry, I couldn't wait, 4, 5, 6 months. I had to do things now. We need solutions. So that we call concurrent intervention confounding, right? These interventions rolled out concurrently to you developing the model. The second way the target moves is action-induced outcome bias. So this is after you've implemented a model, the predicted outcome of that model becomes the target of an intervention. So it sounds confusing, but just to go back to our initial example of an AI model predicting a hospital length of stay, let's say you do implement it in a live EHR. Your predictions are great. It's working really well. Let's say you predict a patient's going to stay 12 days in the hospital, which is a pretty long time. You show that to a clinician. The clinician says, oh, okay, that's pretty long. I'm going to intervene to shorten that length of stay. And let's say they successfully shorten it to be 8 days instead of 12. Well, now all of a sudden, you have no way of knowing if that initial model prediction was correct or was it wrong from the get-go. Did the intervention work and shorten it, or was the model just wrong? So to summarize these two issues, right, there's concurrent intervention confounding. So the predictions are inaccurate from the start, whereas action-induced outcome bias is that the predictions probably were accurate, but the intervention in response to them made them appear falsely inaccurate. So what I tell stakeholders when we sit at the table with them is there's a very simple way to solve for both of these problems, which is a short-term implementation with a randomized design with a control group. And a lot of times people hear, an RCT and they shut down, but we say, no, it's okay. We only have to do it for 3, 4, 6 months tops. And we're already going to be impacting half the patients or half the stakeholders, whatever it may be. And this usually is enough to convince them to say, okay, we'll do it your way and then report back. So with that being said, we can jump into the 3 stories here. The first one is the automated gatekeeper. So this particular model was a cost prediction model that tried to predict what the future spend of a particular population at UCLA Health was going to be. This population is called a Medicare Advantage population. I won't get into all the details, but the idea basically is that UCLA was financially on the hook for 100% of the costs of these patients. So they were very financially incentivized to lower the cost of care for these people while maintaining high quality. I have to give a big shout out to the other members of the team who worked on this: Will Turner, Catherine Sarkissian, John Maffei, and Chad Villaflores from the UCLA Healthcare Value Analytics and Solutions team, as well as actually Leon Spanner and Pandiotis Patousis, who did the heavy lifting for this model. And the way that this model worked is basically there's about 10,000 patients, as you can see, that fall into this Medicare Advantage group. They get run through the model, and I'll go into some of the features that were selected. But the idea is it predicts what their cost will be over the next 12 months. And for the highest cost patients, they then get selected to be enrolled in what's called an ambulatory care management program, or an ACM. ACMs are very widely used tools across the entire nation, which is basically, it's like a call center almost that has case managers, care coordinators, RNs to call patients and figure out ways to prevent expensive care, prevent ED visits, that's emergency department visits, prevent hospitalizations. At UCLA, the ambulatory care management program is called proactive care. So that's what I mean when I say proactive care. Now, this model had over 500 features, used all the usual things you'd expect: demographics, social determinants of health, prior utilization, diagnoses, as well as some structured EHR data. And not surprisingly, the most important features were the prior charges, prior cost of patients predict future costs. So that's not terribly surprising there. I'm not going to get into all the technical details because I think this talk, I want to focus on the implementation and evaluation side of things, but just know it actually did not perform very well in the tests retrospective data. So the R-squared was only about 0.32 to actually predict what the future 12-month cost was going to be. And as other people in this room have shown, if you build a model off of prior utilization or prior cost, but that prior utilization is itself biased due to things like structural inequities in access to health, that risks that the model you implement will in turn propagate those biases. So this model was evaluated for bias and fairness across several different domains: race, ethnicity, social vulnerability index. Just know that there weren't any substantial differences. It kind of performed equally poorly across all different subgroups that were looked at. Yeah, please.
Are another choice to be using forever. So what's the data from building it yourself?
Sorry, can you rephrase?
The Johns Hopkins commercial.
Oh.
Like risk classifier state insurance have been using for
a long time.
Decades, yeah.
Yeah, so there's a number of things. So the thinking is that those work on like a population level. And I think they actually applied those to this particular population. And I think that there's some sort of like idiosyncrasies for when they were looking at this group of 10,000 patients there, where it actually underperformed quite substantially. And because those are proprietary models, you can make very few modifications to them. Yeah, so I think they were hoping that this model was going to outperform that substantially, but it did not. But there's a twist at the end, which I'll get to. So basically, the initial plan before we were involved was to roll out this AI model as a standard implementation, which would look as follows. This is our Medicare Advantage population. Each of these is 50 people, highest cost at the top, going down to lowest cost. And the plan initially was to run them all through this AI cost model. And it was going to take just the top 250, which is what the program Proactive Care could enroll each month. That's its capacity. And then enroll them in Proactive Care, and the others go back into the pool. And this process repeats monthly. So that was the initial plan. But the two problems I brought up, the two-way moving target, you couldn't answer either of the questions this way. You would have no idea how the program performed, and you would have no idea how the model performed because you were exposing all of these people to the intervention. So what we decided to enroll was a randomized waitlist design. So this is a type of randomized controlled trial that's really good for testing these types of utilization and cost prediction models. So the overall structure of this trial was UCLA cares for about almost 500,000 patients that are attributed to it. The MA population, Medicare Advantage population, is a small subset of that. And the model runs on them. Rather than taking the top 250 as was initially proposed, we said, let's take the top 500. After we get the top 500 highest predicted cost patients, we will then randomize 1-to-1, and we'll take 250 of them and enroll them in proactive care. The other 250, we're going to put on a wait list, a 10-month wait list, and we're going to lock them out of proactive care to serve as our control group. So if you look at this design, this actually gives us 2 experiments for the price of 1. The first experiment is looking at just the control group. And here we can actually see in a predicted high cost group of patients, let's compare the observed cost to their actual cost. So we get 1 experiment that way. And we know that they're going to be free of any sort of confounding for 10 months while they're on our wait list. The second experiment is your classic RCT, where we just compare treatment to control. And it's actually going to allow us to, aside from the AI model, evaluate the performance of the proactive care program, which is a very expensive program, millions of dollars to stand up. They have to hire RNs, case managers, everything. So going back to the details, our experimental design looked like this. Same population. We took just the top 500 from the model output, and we do this 1-to-1 randomization here. And you'll see we put 250 of them into proactive care, and the other 250 get added to this 10-month wait list here. And this process repeats each month, whereby we add 250 more patients to the treatment group and then 250 more patients to the control group. And patients keep marching down the wait list. Now, to do this in the most ethical way, we actually couldn't ethically have blocked providers. Like if a PCP felt that their patient needed to be enrolled in proactive care, we allowed them to override the wait list and force enroll them into the treatment group. That only happened 0.4% of the time. So very minimal. But if patients died, or also if they left UCLA, they were taken off out of the trial as well. So that's how the wait list kind of shrinks a little bit. But by the end of the 10 months, you can see that very first group that was enrolled then gets put into proactive care that way. So that's how we tell the health system stakeholders, everyone will eventually get it. We're just going to delay it for a little bit. And that gives us a really nice control group. So we fast forward here. Yeah, please.
One of the things that we learned from the study you mentioned about racial bias in these kinds of cost predictors is that 2 patients with the same cost or predicted cost might be different in terms of their health, because at the same level of cost, a Black patient has less access to care and quicker treatment. So one thing that would imply, and I'm not sure if you have enough patients to do this, to do like the race comparison, but one thing that would imply is that you might actually see a bigger treatment effect for the Black patients than for the white patients.
Yeah.
Because they have the same predicted cost, but the Black patients are likely to be sicker at that same level of predicted cost. And so you might actually find that those patients have an even bigger benefit from being enrolled.
Yeah.
But I'm not sure what the sample size is like. So
it's 5,000 people. It's 500 a month for 10 months.
And about like 10-15% Black.
Yeah, like 12, 13. Yeah.
It might be.
It's worth looking into. Yeah, that's a good point. I'm going to take note of that. Thank you. Yeah, it's interesting because this is like, that on a national level, I totally see that. For this population, it's interesting because by definition, to be in a Medicare Advantage population, you already have access to all of UCLA's network. So it's I'll have to kind of think about it.
It's worth everything. So like pretty well insured.
Oh, they were. Yeah.
Traditional.
Okay.
Either Medicare or kind of a regular private plan.
Yeah.
But everyone was also insured in that study.
Okay, no, definitely worth looking into.
How many people outside of the study are typically enrolled in the proactive care? Does the addition of the study change the quality of care of this program in any way?
It's a really good point. So proactive care was basically running before this happened, and it was like another 250 a month were effectively being enrolled. So we doubled the enrollment size. But the impetus for that was that we found that everyone working in proactive care didn't have enough work. So that's why they said, let's add more people to it. And then they also ended up hiring a couple more people. So interviewing a lot of the people who are working in the supervisors, there's no perception of a diminished quality of care from being overworked or anything. It's a good question.
I have a question of the patients that were in the wait list.
Yeah.
Do you monitor like what the model's risk scores look like for them? Like I'm wondering if some of these patients here they should be bumped up more, maybe because they become higher risk over this waitlist time?
Yeah, so we didn't actively monitor it. The only time that the future cost score was calculated was at the time of enrollment, and then we didn't touch it again. And the reason, like, I think you bring up a good point, like, which is ethically, if these people are predicted to be high risk, is it ethical to keep them on a wait list? And our argument was that the model was already performing so poorly, with R squared of 0.32. There was really no way to know that this patient here was actually going to be higher cost than this patient here. So, from an ethical standpoint, and also we had the fail-safe valve, where if a primary care doc saw a patient in front of them and they say, this person's super high risk, I need to get them into proactive care, they could have done it. So that's kind of how we got around that. It's a good point. So to circle back, so this is our design to answer the first question, how did the model perform? Now, unsurprisingly, not great. We already knew beforehand it didn't perform super well. I'm going to put some numbers on this in a sec, but you'll see this is the log of predicted cost on the y-axis with the actual cost on the x-axis with, of course, the dotted line being perfect correlation. We're pretty flat on that, and this is across multiple months of enrolled cohorts of patients. And when you put numbers to it, you can see that these R squared values basically range from close to 0 to the highest one of just 0.16 there. And this is across multiple months, again, of enrolled patients. So where it was performing on retrospective data with an R squared of 0.32, at best, it only did half of that when we deployed it in a live EHR environment. And that's, again, because what we talked about, the idea of concept drift, prediction decay, all of these things kind of took hold. So it was very interesting to see that actually happen in a real world scenario. So the model was performing even worse. But, and here's the twist, we looked at it a different way. We said, while it wasn't good at predicting the precise cost, is it good at coming up with at least like an ordinal rank list of which patients are going to be higher cost relative to others? So this figure looks at the actual cost decile. So this is the true highest cost 10% of patients, then the next 10% of patients, so on and so forth. This is the percent of the predicted high cost patients who ended up falling into that decile. So to interpret this, this is at 50%. This means right here that of the actual highest cost decile, the model, 50% of the people the model predicted actually fell into that decile. And in this case, 25% of the highest cost people the model predicted actually fell into the second highest cost decile. So when you put those together, what this means is that really 75% of the highest predicted cost patients did end up in the top 2 deciles of cost in reality. So that doesn't paint a picture nearly as grim as the R squared did. And what it kind of points to is this concept of in-silico operational discordance, right? Which is just saying that there is a gap between the technical performance and the clinical performance of a model. So even though this model was very poor at predicting the precise cost, it was pretty good at categorizing people into deciles. So I think it's an important lesson, because even if you have a model that has a bad AUC or a bad R squared, don't throw it out. There might be a way to actually make clinical use of this. To answer the second part of the trial, which was the pure RCT, did the proactive care model actually work? I'll just quickly show, oh, it's actually even lower. Yeah, it was 7 or 8% for Black African American. But we had 5,000 patients split evenly. I won't spend too much time here. They were relatively balanced between the groups. And what we found is that there was no statistically significant difference in healthcare expenditures between the two groups. So there was maybe a slight trend towards lower cost in the treatment group in proactive care, to the tune of around $880 in the first 300 days or 10 months, and then to maybe $300 lower in the first 12 months compared to the control. But for a program that cost millions and millions to stand up, this was a very surprising finding and highlights the need for us to test all of these things in rigorous RCTs there. So the takeaways from this, number one is just this concept, like we mentioned, of the in-silico operational discordance. And then number two is that this is an example where a model triggers an intervention that all of the patients it triggers on get exposed to the intervention. This is going to be in contrast to the next story that I'll tell. Yeah, please. Yeah.
So, I personally, I think you also don't find this super surprising, even though surely other people did. And the reason is that even if you are purely interested in reducing costs, let's say you didn't care at all about it.
Yeah.
Even if you just want to reduce cost, it's not at all clear to me that enrolling the highest predicted cost patients is the right way to do that.
Mhm.
Because predictable costs are very different from preventable costs.
Yeah.
And so I imagine, and like when we looked at the data, it's from Boston, totally, but the highest predicted cost patients are people with cancer, people with sort of like rare, expensive events like childbirth or knee replacements, or like, so
Mhm.
it highlights to me that, you know, it's related to some of the caveats you mentioned about basically like predicting a thing is not the same as the treatment effect of something on the thing.
Yeah.
So if you looked at, you know, some of these high cost patients and segmented them by just like your clinical view of whether these people have preventable costs because they have diabetic complications that could be better managed by medication, because they have heart failure that could be better managed by whatever. Like, did you try looking at any of the subgroups, even though with all the caveats about subgroup analysis?
Yes.
And and I think the reason it's interesting is because lots of people in this space are like, I want to reduce costs, therefore I have to predict costs. But that is just like not logical to me at all.
Yeah.
And it seems like, yeah, that you could maybe help people figure out the best predictions by finding subgroups where, yeah, there's more treatment effect.
I think it's a really good point, and especially because we know there's going to be a regression to the mean, right? If you're looking at people whose last year was super expensive, it's probably this next year is going to be less expensive. If anything, you should look at the lowest predictive cost and intervene on them because they're more likely to have rising costs. But yes, that's true. And we actually did, and I should say, I have to figure out how to get this up here. But yeah, so I'll tell you, I can show you the slides, but we did look at specifically what are called kind of ambulatory care sensitive conditions and also preventable ED visits. So those are the things for heart failure, for diabetes, for things like that. And there was no difference in utilization either. So the same rate of ED visits, same number of hospitalizations, same length of stay. We were really, scraping for anything.
Third decile would be a better target.
Yeah.
The third what?
The third decile.
Oh, the third decile. Oh, yeah. Yeah.
It's too sticky, like the
Yeah.
cost is too.
Yeah.
Related to stuff that is already hard to.
Yeah, that's a good point.
Yeah, or there's a mismatch between the intervention that you have, which is a nurse practitioner, going to help people with stuff.
Yeah.
And the things that people
Actually need help with. Yeah. Like they need a family member, they need, somebody to sit with them 24 hours a day. Yeah, something like that. Yeah. And I think so I should mention, so this whole study, it took 22 months because, it was 10 months of the wait list. And then we had to wait 12 months for the last cohort to finish enrolling to look at their cost. So the last cohort actually finishes up in April. So at that point, then we'll look at the third decile, look at all of these other things and dive in more. Okay, I'll skip through this here. But yeah, we looked at utilization too. Okay. So the second story that I want to tell is a human in the loop partner. So the background for this is that the US is on the precipice of a hospital bed shortage. So this figure here shows national hospital bed occupancy on the y-axis and time on the x-axis. And where we are now is boxed in red. And this is at 75% national hospital bed occupancy. So 3 out of every 4 of our hospital beds in the country are generally occupied. It doesn't sound like a lot, but when we get to 85%, that's what experts consider to be a hospital bed shortage. And that's when we start to see drastically increased ED boarding times, the time it takes for you to get a bed upstairs when you get admitted. We start to see medication errors from overworked pharmacy techs and nurses. We start to see misdiagnoses from burnt out physicians, and worst of all, increased mortality. So when you do some forward-looking modeling to say, what would it take to actually push us to that 85% threshold? It turns out it's not that much. The aging US population alone and the fact that they need the hospital up to 5 times more than their younger counterparts would push us to a hospital bed shortage as early as 2032. But that assumes that we do nothing. So there is hope here, which is that if we can reduce the demand for hospitalization by 10% over the next decade, or increase the staffed hospital bed supply by 10% over the next decade, or some combination of the two, that would be enough to avert this hospital bed shortage. So our solution for this at UCLA is something called the next day clinic. And the way that this works is that we take patients who are coming into the ED and they get worked up as usual. And we are targeting low acuity patients. They're called kind of soft admits. These are people who typically come into the hospital just for 1 or 2 days, and then they end up discharging home. What we have on every single one of our patients that walks in through our ED is a model that runs that predicts who these people are going to be. And we try to instead divert them to next day clinic. So the way this works is, let's say it's 11 p.m. and the person comes into the hospital, they get their first dose of antibiotics in the emergency department. They then go home, and then the following morning at like 9 a.m., they'll come back to our clinic, and there they can get more IV antibiotics. They can get IV diuretics for heart failure, labs. We can do advanced imaging. We can do remote cardiac monitoring. Basically, our motto is whatever it takes to keep them out of the hospital, we will do. After coming to the clinic, they then get to go back home and enjoy all the benefits of that. But importantly, they don't just come once. They get to come back to our clinic daily, every 24 hours, as many days in a row as needed, in order to get them out of their acute illness episode, and then we transition their care back to their primary care team. So to make this relevant to this talk, the question is, so what is this model that is running and identifying these patients? And it is the most rudimentary model you could ever imagine. It just only looks at labs, vitals, and basically the diagnosis, all that happened within the ED there. And it's a very simple task. It just tries to predict, are you going to stay above 48 hours or under 48 hours? The reason for this is because this was dreamt up years ago. The prospect of building a real-time AI model into the EHR like wasn't even a thing back then. So it had to be like the most dumbed down version of anything. And unsurprisingly, the positive predictive value is quite low. So for that reason, we need a human in the loop. Just worth mentioning, I'm working with some faculty members in CPH, John and Maya, to hopefully implement their large clinical behavior model and replace what we currently have, which would hopefully drastically increase the predictive capabilities of this. But that's for the future. Right now, what we did is, this is what's called an ED track board. This is how you see every single patient who's waiting in the emergency department waiting room, waiting for a bed upstairs, everything. We built a new column into the track board called Next Day Clinic Eligible. And if that very basic model predicted somebody was going to stay under 48 hours, a little flag appears there. That flag then triggers a cascade of events with humans where we have our own case manager who sits in the emergency department, who first screens these people. And if they agree the person's appropriate, then they escalate it to the ED physician, who then screens the patient. And then if they agree, then they finally go to next day clinic. If either of these two humans disagrees, they get admitted as usual.
Just for the sake of people who haven't been through this pain, can you explain what it took to get that column added on?
Oh, God. So yeah, this was it was to do everything with the model and the column, everything. It was about an 8-month process. It took over 1,000 hours of build analyst time. We had to present, for like four different stakeholder groups, governance committees, all of this. And it was, it's not easy.
I mean, I think the headline here is that it only took 8 months because this could have taken a lot longer.
It's true. Yeah. Yeah. And there was a lot of like other build on the back end here, but fortunately, like we've got it kind of streamlined now. So future efforts are a lot faster, but yeah, it was quite a lift.
Negotiating down from full automation, or was it your idea that this is
So I think I quickly realized that like right off the bat so we started talking about this in like 2021. So at that point, I knew right away we were never going to have a model that was good enough to operate autonomously. Okay. So pretty much right from the get-go, I was like, okay, we need to get an FTE for this person, all of these things. So in the future, I would love like a fully autonomous closed loop system. So we designed this. The last one you saw was a randomized waitlist design. This is designed as a randomized encouragement trial, which is another really powerful way to design an RCT for one of these kind of predictive models, especially with a human in the loop. So the way that this works, the patient comes in, they're eligible for next day clinic. The decision is made to admit them. So we know that they're coming in, and our model runs on these people. And right after the model ran, if they were determined to be meet our criteria and we're going to get flagged, we actually first check the patient's birth date. So if they were born on an even day of the month, the 2nd, the 4th, the 6th, then the flag appeared. If they were born on an odd day of the month, like the 3rd, the 5th, the 7th, we did not fire that flag. We suppressed the flag and we just let them get admitted as usual. So what this yielded was a treatment group comprised of patients who were treated in next day clinic, but also still some patients who were admitted as usual. Because if either of the humans, right, said no, they still got admitted. So we did this as a intention to treat analysis. We grouped all of those patients together to be really rigorous. And then our control group comprised of patients who were admitted as usual, but still, just like the last trial, to be ethical, we did allow some of the ED docs to still refer to next day clinic, even if that flag didn't fire. And then we compare the two groups. Our primary outcome was a popular outcome in clinical trials called days alive and out of hospital, or DAOH, which is basically, in this case, of the following 30 days from your ED visit, how many of those days were you home and alive? So 30 is the best, lower numbers are worse, indicating you got rehospitalized or you died. I'm not going to get into all of the consort stuff, but this is actually preliminary. We launched this as a 2-site RCT. This is just the results from the first site. The second site we just finished enrolling last month, so I don't have those data yet. But there were 437 patients split evenly. Good balance between the groups. I'm not going to stay on this, but I'm happy to send it to you. And at this one site, so in the first 6 months, we enrolled 87 people after all the exclusions and everything. 64 of them were in the treatment group. 23 of people treated in the next day clinic were in the control group, which is actually very, very good for a randomized encouragement trial, because what that means is that our encouragement resulted in treatment uptake of 30% compared to only 10% contamination in the control arm. So that means our encouragement worked in a 3-to-1 ratio at getting providers, nudging providers to refer to next day clinic, which is more than enough to get statistically robust results here. So what we showed through our primary pre-registered analysis here was that referral to next day clinic was associated, or really resulted in 4.4 more days alive and out of the hospital for people referred to next day clinic compared to those who were hospitalized as usual. And there was no statistically significant difference in 30-day readmissions. And then most impressive are the cost savings. So the actual cost to UCLA Health to care for one episode of care in next day clinic was about $400 compared to over $13,000 for the hospitalized counterparts, imputing cost savings of nearly $13,000 per referral. And of course, we haven't stopped enrolling patients in next day clinic since the trial ended. So more updated numbers are over 300 avoided hospitalizations. And if you multiply that out by the metrics that we got from the trial, that amounts to over 1,300 bed days saved and nearly $4 million in avoided healthcare expenditures. And hopefully, we'll get the other results from the second site pretty soon and share those. With the takeaways here, and then I'll let anybody ask questions, is basically that this human in the loop method can be highly effective, but as we saw, very resource intensive. But a great way to test it is through a randomized encouragement trial. And this is in contrast to the last one where 100% of patients got exposed to the intervention. Now, with our encouragement, about 30% of patients got exposed to the intervention in our treatment group, but still very studyable. Any questions there? Yeah.
One clarification talked about is those are just direct costs. And
Yeah.
they don't account for the opportunity costs of the bed.
The backfill, yeah.
And for context, at a hospital like UCLA, there's a lot of patients that are waiting to get into the bed. Have you tried to actually just cost out, if you actually did the accounting the way hospitals should do the accounting, what would the additional revenue be from freeing up those hospital beds?
It's a really good question. So I have been trying for some months to get my hand on what's called an outside hospital transfer wait list. Which is exactly what you're talking about. There's people who, are coming from community hospitals, rural hospitals, and they need a liver transplant or kidney transplant. Those make the hospital a lot of money, but there's a wait list for them. So if you can get that wait list there, then you can figure out, we have to make some assumptions. Like for every 20 patients we avoid a hospitalization, you get to take one extra person, something like that. Then we could cost that out. I'll let you know when I get those.
How did patients respond to the next day treatment?
Yeah.
And were they pretty willing to come back from the
Great question. So for the people who came, who actually ended up like agreeing and coming to clinic, exceedingly well. The feedback was so positive, and we actually we surveyed all of them, and we compared it to we also surveyed a portion of the control group too, and we compared the two. We actually had higher satisfaction scores for people who went to clinic rather than those who waited in the ED. We heard stories like people saying, I was going to get admitted to the hospital. I don't know who would have fed my cats while I was in the hospital. Like, this allowed me to go home. Like, it meant the world to me to be able to do that. We also we offer people free Lyft rides. We'll pick them up from their house, bring them to clinic, send them back. They live really far away. We'll put them up at a hotel at no cost to them to keep them close to the clinic. So all of those things, people love all that. What was the second? Did you?
Were they willing?
Or were they willing? Oh, yeah. So we had, of people that were ultimately deemed eligible by physicians, we had about 70% acceptance rate of that. So still 30% of people said, no, I want to stay here, but that's kind of to be expected. We actually, the marketing team made us a really fancy video that we started showing patients on iPad. That helped also. But in general, people were pretty happy to come. Good question. I have not done that like in-depth analysis yet, but we'll definitely look at that. Yeah, some chart review there. All right. So for the final story, this is the behavioral nudge. So the clinical background for this one is that prediabetes in the US is horribly overdiagnosed. The diagnostic framework for it is based on a lab test called hemoglobin A1C, which is a blood test showing the 3-month average blood sugar that's circulating just in your body at any given time. The idea is if you're under 5.7%, then that's considered normal. If you're between 5.7 and 6.4%, then that's prediabetes. And if you're over 6.5% or above, then you have diabetes. But this is a very blunt tool, right? We know that blood sugar metabolism naturally changes with age. And as we get older, our bodies aren't able to metabolize blood sugar as well. So our blood sugars naturally raise in many cases. So it's kind of crazy that in 2026, we use the same diagnostic criteria for a 25-year-old as we do for an 85-year-old. And this is not just for prediabetes. This is across the board. We apply just very broad diagnostic criteria, which blows my mind. But older adults are most affected. So there's been some observational studies showing that without intervention, older adults newly diagnosed with prediabetes often don't advance to full diabetes. They end up just dying with prediabetes. So giving them this potentially stressful diagnosis induces a lot of unnecessary anxiety and can reduce their quality of life in the final chapter of their life. So, and by the way, the prediabetes threshold in Canada is different. So it starts at 6.0. So if I have prediabetes at 5.8 in the US and I drive to Canada, I no longer have prediabetes. So this is all completely contrived. But we set out to solve this by asking the question, can we develop a model that will predict which older adults with a new diagnosis of prediabetes will actually get diabetes within 3 years? And just for the sake of time, I'll just jump right to some of these metrics here. So on the left, we have the average precision. On the right, we have the AUROC. And the bottom curve here is actually the existing risk model, one of the most widely used ones. It's called the Kent model. And it's the bottom one in both cases. And you can see our model, which, by the way, was trained on 5 years of data from the UC Health Data Warehouse, which, for those that aren't familiar, it's some EHR data that's contributed from all 5 UC health systems, and it's standardized to the OMOP data standards. This is all still very much a work in progress. So right now, the models are broken down by year of cohort. So that's why like 2020 is separate from 2021, from 2022. We will aggregate those. But you can see that our best performing model was a CAT boost model. And I think in our best cohort, like it was a 2023 cohort, we got an AUC of 0.89 and an average precision of about 0.5. The most important part is that it outperformed the existing risk model that's widely used. So we said, let's see how we can implement this in a live EHR environment. Just to give you a quick sense of some of the features it used, there was over 60 of them. Not surprisingly, the most important ones were things like their prior A1Cs, their prior glucose, BMI, as well as certain aspects of their cholesterol lipid panel, like total cholesterol, triglycerides, etc. So when we said we wanted to implement this, we decided we were going to do the minimum viable product, which was just taking the lowest risk patients and telling them that they were low risk. So we said, if we're going to do that, we want to set a threshold determining who we're going to display this to. And we need a threshold. We just kind of arbitrarily said we want 0 false negatives. So we don't want to inadvertently tell somebody that they're not going to get diabetes, but then they actually do. So when we looked at this in 1 year of our test data, we found that if we had set this threshold, that we would have not really captured much of the population. In this case, you can see that of people who truly did not get diabetes, there are about 1,000 of them in this 1 year of test data. We would have only captured about 160 of them, so about 15% or so. So we're like, that's not really going to make an impact. So we engaged in this threshold selection exercise. And to interpret this, ignore the gray lines, just look at the red lines. And what you see here on the x-axis are the number of allowed false negatives. And on the y-axis on this graph on the left, this is the absolute number of true negatives we gain for each additional false negative we allow. Whereas on the right, it's just depicted in a ratio. So we're really looking for that inflection point where we see that for allowing an additional false negative, it's no longer efficient because we start to get diminishing returns in the number of true negatives that we get. So the sweet spot ended up being right here, just around 5 false negatives. So we said, okay, let's put that into our test data and see how that would look. And with this, there was about 3,000 patients who truly did not develop prediabetes, and we successfully identified just under half of them with only about 16 false negatives. And we said, well, if we're going to implement this, we need to go to all the proper stakeholders and make sure we're doing this by the book. So we went to patient stakeholder groups, community engagement groups, the American Diabetes Association, endocrinology stakeholder groups. And we presented this threshold along with a more conservative one, where we had very few false negatives, as well as a more liberal one, where we actually captured about 66% of the people who did not develop diabetes, but with a much higher false negative rate. And with all this stakeholder feedback, we ultimately decided on this optimal threshold here and decided that the benefit of alleviating the anxiety of the unnecessary diagnosis outweighed the potential risks of the small false negative rate there. So this is actually an RCT that we're in the process of launching right now. So I don't have results from it, but I want to share it for a couple of reasons that you'll see. So we run this model on all patients 65 years and older who are having a hemoglobin A1C drawn. All of those results get put through a prediabetes risk model. But this, to Ziad's point earlier about the technical build, this is one of the most difficult technical builds I've ever engaged in, because right now at UCSF, at UCLA, at any health system that uses Epic in the nation, as soon as a result comes back, it immediately gets released to the physician and to the patient. So to run a real-time risk model on that and try to display a risk score simultaneously with the results is nearly impossible. So it took a ton of work, but we found a way to, in a pre-production environment, freeze the results before they got released to the patient and the physician. And while they were frozen, simultaneously run the risk model on that and determine if they were low risk. So the way that this worked was that on pre-production frozen results, if it came back at under 5.7, so no prediabetes, over 6, which we said was too high risk because we wanted to be really conservative, or they were between 5.7 and 6, but not low risk by our model, we unfroze it and we released it. If it was between 5.7 and 6 and low risk, then we had a third layer where we did a spot randomization, 1-to-1 with patients, where half of them are shown their risk score and the other half see the A1C as usual. So this build was even harder than the last one because we had to freeze, run the model, and then randomize before releasing, which was like a crazy amount of work. But it's finally ongoing. So the way that this works now is that we have a clean treatment group. And again, to be as ethical as possible here, and this was based on the feedback from all those stakeholder groups, the way that we organized it is that we didn't suggest a specific action. We just presented that they were low risk, and we let the physician and the patient engage in shared decision-making and do with that information what they wanted. Whereas the control group just got the results as usual. And then we are comparing the number of prediabetes diagnoses, endocrinology referrals, how many meds are started, and quality of life. We're surveying all these people as well. So I'll just wrap up by showing you what this looks like. This is the status quo. If you get an A1C of 5.7, you get this alarming flag that says it's high. Whereas in our treatment group, that result's still down here. We remove the flag, but we've added in this risk piece. So we added a panel to the results where it just says you're low risk. And you give a little bit of information where we say, based on your health profile and hemoglobin A1C, your risk of developing diabetes in the next 3 years is very low. This is based on data from you and more than 18,000 patients at UC Health, considers 94 individual characteristics, including blah, blah, blah. So this is what patients are seeing now. And the takeaways from this are basically, this is an example of a behavioral nudge where you present the model output, but in contrast to the prior two examples, we're not making any specific recommendations. It is light touch, yes, but the nice thing is it's very straightforward to launch a parallel arm RCT. So I'll wrap up by just saying these are the 3 stories we told. The automated gatekeeper, where it was kind of a more heavy-handed intervention, 100% of patients got the intervention. The encouragement, which is the human in the loop, and then the nudge, which is the lightest touch of all the 3. So thank you so much.